Good afternoon, everyone. I'd like to welcome you to our final Medical Director training today. My name's Barb Repkin, and along with Tara Rosario, we work in the General Practice Improvement and Digital Enablement team here at Eastern Melbourne Primary Health Network. We'll start today's session with our acknowledgement of country. Next slide, please, Tara. Eastern Melbourne PHN acknowledges the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past and present. We are committed to the healing of country, working towards equity in health outcomes and the ongoing journey of reconciliation. We recognise the value and wisdom of people with a lived experience, their supporters and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution they make to the development and the delivery of health and community services in our catchment. Next slide, please, Tara. Some housekeeping. Today, all attendees will be muted. We have quite a large group today. Please use the chat function to add your questions. These will be answered during the session, so you don't need to wait till the end, but there will also be time at the conclusion of the session to ask further questions. We will be recording the session today, and attendees will be provided with the recording and a copy of the slide deck as well. Next slide, please, Tara. This is our agenda for today. We have data quality, data cleansing, the 4.3, the new enhancements in Medical Director and PracSoft, template management, sending emails, My Health Record, including the NASH and the setup requirements, the patient search utility, Medical Director utilities, and setting up permissions and configuring users and managing appointment types. So now I'm going to introduce you to Grant Smith and Kylie Goodwin from Medical Director, who between them have almost 30 years of experience. So I hope everyone enjoys the session today.
Making sure I'm on mic. Great. G'day everyone. My name's Grant Smith, Medical Director, Telstra Health Practice Consultant. Kylie joining me today. Kylie has full ownership of our slides. Our slides are awesome today. So if you've ever done training with me before and you've gone, gee, Grant, those slides are good. You didn't have them slides last time. Yeah, that's right, because Kylie did the slides. She's awesome. I'm terrible with paperwork. Kyle's is good with it. So without further ado, let me share screen if I may. Where are we? Over into here. Hopefully that should now be getting us a screen up. Looks like about right. Okay, so folks, we are doing 4.3, working on 4.3 today. 4.3 went out in Valentine's Day earlier this year. I did a joke yesterday about flowers, but I think there were some emails went through actually asking for flowers to the marketing team, so I won't make any jokes about, you know, if you didn't get flowers, please send an email through. No, don't, please. Please don't. But it was out in February this year. You'll see we'll be talking through a few changes about, we've got the first thing on the slide is data quality and data cleansing, and some of the changes in 4.3 are relevant to those data cleansing and data quality improvements that we've concentrated on in 4.3. 4.3 has probably been the first version in a long while where we've actually been able to get some user requested items into the list. There's been quite a few. Very shortly, I'll take you over to another slide, which will go through some of the 4.3 enhancements, but I just want to take you through some of the things that straight off the bat hit people. In terms of 4.3 changes, of course, there is the upcoming changes to AIR required by, I think, 5th of December, if Kylie informed me correctly and I read correctly, for making sure that everyone has 4.3 installed by the 5th of December if you are an AIR prescribing or an AIR immunising practice. If you aren't an AIR immunising practice, in other words, you don't upload immunisations to AIR, you can continue with 4.2, for a much longer period if you need. But as I say, if you are wanting to be compliant with AIR rules, by 5th of December, you need to have 4.3 in. I'd say probably more than half of our users currently have 4.3 on. It's going reasonably well. It's probably worthwhile just making sure if you haven't upgraded to 4.3 that you make sure you have what they call the environmental configurations, or your IT has got their environmental configurations configured correctly. I haven't previously mentioned that to the doctors and to the nurses because usually they're not dealing with that sort of stuff. Unfortunately, we're in the practice management world. We have to deal with everything. And the whole IT structure, unfortunately, just by default ends up in our lap because everyone else usually goes, I don't want it. No, it's yours. So that's some stuff there. So in terms of some changes for 4.3, you'll see now that we have multi-location in the login. When I come to log in to Medical Director, I can be logged into a multi-location. That actually affects some of the stuff about PIP-QI uploads for shared health summaries. Forgive me if I use acronyms, guys. I'm presuming everyone's across the same ideas of practice incentive program, quality improvement, and all the other acronyms we come across. If you aren't aware of acronyms, please do not be ashamed to ask acronym questions in the chat. So if the heck, what do I mean by what was the one we came across earlier, Kylie, we were talking about for the aged care one?
Hacky?
Yeah, I thought you were talking Greek to me or something. It wasn't. There's nothing wrong with speaking Greek, but I speak Greek, mate. So all these different acronyms we come across. If you've got questions about acronyms, we do use them regularly. Please don't be embarrassed to put in there into the chat what does agape mean, or whatever the case may be. So please don't be ashamed to ask any questions. We'll try and get them as we go through. All right.
I'll add the slide into the chat just so that everyone can have a quick read, just in case they're obviously wondering what that means.
What the heck is that? Fair enough. Well, it's nice to keep people, engaged, mate. What's he mean by that? All right, so let's log in. When you're coming into 4.3, if you've been using Medical Director for some time or from 4.2 previously, you'll be getting this pop-up if you haven't turned it off already. The whole idea of these particular updates here is to show that when you open 4.3 for the first time, these are the changes. Now, goodness knows everyone will probably ignore this pop-up and immediately go close. That's fair enough, not hassling you. I recommend that if you are going to do that, just hit the do not show this message on next login so it stops hassling you next time. All right, I'm all for make less clicks. All right. So in terms of do not show message on next login, once you've read it, get it out of your face. I'll leave it on because I need mine, because otherwise I'll forget. And of course, as a trainer, I need to show people how this works. Okay. Now, in terms of when you're coming into MD itself, of course, none of this stuff is really changed that much. There's been a couple of little tweaks here, but I'm not going to talk too much about this area in here. What I do want to talk to is the significant changes in the user area in here. In the setup users and how we've got this area here. You'll think, yeah, there's no changes here. There is significant change down here with one button and one button only, manage permissions down the bottom of the screen. All right, this plays into this data quality and data cleansing stuff shortly, and you'll see why. All right, out of the box, a lot of these settings are off for users. So when you migrate from 4.2 to 4.3, these new managed permission settings come on, and invariably people will send me an email or give me a call and say, Grant, yesterday I was able to make letter writer template changes and today I can't. What have you done to my computer? And I go, have you upgraded to 4.3? And they'll go, yeah. They go, right, go into here, go into the user list, find yourself or find the doctor in question, click the manage permission button down the bottom and update the permissions accordingly. Now in this example here, I've turned them all on because I'm the power user in this practice. So I've turned them all on for me. And the last thing I want to do is start, don't add letter writer template. I end up to try and demonstrate to you guys how to do a letter writer template and it's all grayed out. And I'll be going, you're not helping yourself. Great demonstration, mate. Bad work. So in regards, there's a couple of things we'll talk to here. In regards to this result management, how many times have we been begged to get this sort of stuff in where we can stop doctors adding their own notations? All right, you can do this now. All right, and you can also stop doctors from deleting notation. Less relevant there. Certainly, the add notation is much more important, I think, in my opinion, for a data quality perspective. Same with the clinical button up here, which really should, in my opinion, say clinical recall, just up the top there rather than saying clinical. But nitpicking at our own team rather than you guys. So in regards to adding recall reasons and editing recall reasons, very important for this data quality stuff. All right. The letter writer templates, yeah, important. You don't see, generally speaking, many GPs making an absolute dog's breakfast of letter writer templates, and I hope I'm touching wood there. But in terms of the, who does end up making mistakes to letter writer templates quite often is your registrars. Don't get me wrong, registrars, the salt and butter of general practice, or whatever we need to be calling them, but we need them. But they tend to get a little bit adventurous when it comes to doing computer changes. So if they get a little bit too adventurous, we can rein them in here. All right. This is first stage of permissions changes in 4.3 and moving forward. We've certainly, cottoned onto the idea that we need to make more granular changes to permissions in MD side of things. In Praxoft, we've got 8 levels of security level changes and tweaks and various things we can do in Praxoft. In MD, it was a little bit more brutal, so we're starting to move towards a more granular permissions control model here, where we can start to turn things on and off for users. Okay. Okie dokes, let's jump out of there. In terms of our data quality and data cleansing, mainly that's going to be in MD. All right, your data cleansing and data quality is not so much in Praxoft. A little bit, in terms of appointments and that sort of stuff. Patient demographics, patient information updates, of course, very important. In general practice, we should be doing our through identity check when the patient presents. Are you still living at blah? Are you still, and your date of birth, Kylie was 1st of June, blah, 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 or whatever the case may be. So you make sure we're doing those. So from the Praxoft side of things, data quality is not so bad. It's mainly in MD where we're talking about the doctors, nurses making decisions in here where they may not necessarily have been given appropriate education and guidance on how to use this effectively, which is sometimes where we in the practice management will have to give them a hand there. All right, so in terms of some of the things we want to be looking at, of course, the first thing we need to be looking at when we're looking at issues and in terms of quality improvement, I'm not saying we have problems, so we can always do quality improvement. When we're going in to log into patient's file, of course, it's very important when we're logging into a patient's file that we're presented with the right information. Now, I'm logging in as a doctor, just so everyone's aware. You're getting these prompts coming up on the screen. Prompts are important from my perspective to make sure that you have the right prompts for the right people. All right. If you're practice manager and you don't do nursing, like if you're a nurse, practice manager does nursing as well, sure, we'll have a chat. If you're at yesterday's meeting yesterday, then great. But otherwise, we want to make sure that people are getting the right prompts here. If you're management or you're admin and you don't do any clinical work, turn off the majority of the prompts. Don't turn them all off, turn off the majority. All right. And I'll show you how we do that in a sec. All right, currently I'm getting a prompt on the screen about the patient's birthday was on Sunday. All right, normally this is where I'll be getting medication prompts and that sort of thing. If there are medications out of date, then certainly that's where they would be coming in. In terms of the information presenting on this screen, for your landing screen, if you're currently landing on the current RX screen, when you come into medical director and your practice manager, don't. I recommend you don't. I recommend you start as a practice manager, pure practice manager, non-clinical, in progress notes. All right, you may say, Grant, how do I do that? The way we do that, no patient on the screen, no, tools, options, clinical. All right, just pause there for a moment so everyone can see what I just did. Tools, options, clinical at the top there. All right, and you've got this section in the middle here called open patient in. All right. By default, out of the box, Medical Director 32 years ago was written as a prescribing software. That's why out of the box it is current medications for everyone. All right. I would recommend for your staff members, non-clinical staff members, open patient in progress notes. If it's your doctor, well, then have a chat to your doctor because they will often look at current medication. Given they're an experienced doctor or senior doctor, pick your fights. I wouldn't pick a fight about this one. If they're a more junior doctor, I would encourage them to go to summary. If you're a nurse, please don't have a discussion. Just go straight to summary. Do me a favor. All right. Just nurses, put them straight in a summary. Doctors, have a discussion. Doctors don't like being railroaded. Nurses don't like being railroaded either, but nurses is a good reason why we do it in summary. And we'll show you that in a second. As I say, let's go into summary for myself. I like to keep my own summary. And we'll talk about a few things here in terms, it's probably a good idea now, we're talking about the data quality and data cleansing, about mandating and entering a reason for contact for each consultation. All right. In terms of has it been crashed? Has it been improved? We'll talk about that in a bit later. Mandate entering a reason for contact for each consultation. I would also potentially put into progress notes either prompt for Medicare item number. I'm not going to turn that one off myself because I did that the other day with the GPs and drove me mad by the end of the consultation because I don't do the billing. Now, in terms of prompt for Medicare item number, if your doctors do the billing through the MD system, great, turn that on. If your doctors just walk around with a post-it note, the inevitable post-it note, 23BB or 36P for private, whatever the case, and they hand it over to the reception or they tell them verbally, don't worry about prompt for Medicare item number. All right, forget it. Whole idea of this is that, especially a few years ago, we had that shared debt recovery. I don't know if you remember that. That was a while ago. But certainly there was an issue where there was a discrepancy what was being requested by clinicians and what was being charged by staff. We actually brought in a system where in Medical Director, I can put in Medical Director in my clinical notes what I wanted from a MBS item point of view, all right, or from a billing point of view. So very useful there if that's something you do. If shared debt recovery is something, do I need to open up every user set of these options you're talking about? Yes, unfortunately, Jenny, you do. These are individual settings for each person. So you can now override people's passwords. So that is the good news. The way you do that password override, you can either do that in Praxsoft or MD. You can certainly, just be a little bit cautious of that, how you do it, of course. Just explain to them you've done that, just so you can update and set some options for them. Here's the new password, encourage them how to update the new password accordingly. Way you do that, user, set up users. You'll see there's password security settings there. That's a recent thing for e-prescribing compliance. And basically that's where you can set in some of that stuff there. I'll also show you where we put the logout, timeout settings as well. So we're going into user, going into setup users, and you'll see down the bottom here, we should see password. All right. And it's from there I can allocate the new password. All right. It's a good password I picked up. If you're going to talk about allocating general system passwords, a good, useful little one that I found in terms of for generic, and I have to credit the Australian Digital Health Agency for this one because this is their generic password for their training servers, is capital P at SSW0RD. That way you can get the compliance, a special character, uppercase, lowercase, number. That ticks all the boxes. Give that password to the doctor and say, look, I've changed your password. It's currently this. Please change it back to your normal password because I've updated those accordingly. So, yeah, possible. Let me jump back into where we were. All right, so in terms of that particular going into the patient's file, as I say, those particular options there in terms of to help with that side of things as well. Progress notes there, mainly talking about that prompt for Medicare item number. Some people used to do the prompt to confirm visit type. It's sort of gone out of fashion. Prompt to confirm visit type came in about 3.16. It was mainly actually to assist with Aboriginal community controlled health organisations. As I said to the business at the time, only about 5% of our customers were that. Why did we have to deploy it to all of our customers to make them do that? Anyway, old history, let's not worry about that now. In terms of other things in here that I would change, go through your prescribing stuff with your doctors because some doctors like stuff in Latin, some people don't like it in Latin, just weird stuff like that. These really aren't big dramas for quality control stuff. What I do want to show is potentially looking at our recalls. Our recalls, often people tell me my recalls is completely out of control, Grant. How do we fix that? If I quickly go and have a look at our recalls area, usually our recalls are coming in from our holding file. All right, so if we're coming to our holding file here, if you've got multiple entries on here, you can change the GP to change their password. How do they do that? Hopefully that was, I'll just explain there, Helen, how to change the password. In terms of the password update frequency, I'm pretty sure that was on that password settings there, and you've got the login expiry there. And you might just set that to say 900 days or something like that. That's 365 days, of course, being the year. 900 would be, 2 3/4 years or something like that. If the doctor comes along in 2027 and he's wondering why their password changed, we'll cross that bridge when we come to it. But certainly that's how you can set that length of changes. So once again, Helen, just for you, I'm going there into no patient on the screen, user, and password security settings. Okay, we would have liked to have put it onto this particular area here. We were sort of running out of screen space to put extra buttons, so they put it on the other area, so fair enough. I'll also, whilst we're talking about one, talk about the way you can stop the program timing out every 15 minutes. If you just got out of box settings, that the program will time out after 15 minutes. Where you do that from is practice. All right. In this example, I've got multiple locations set up. I'm just going to edit one of these locations, and you'll see there's my time lockout on activity. So in this example here, I've got 90 minutes. I don't recommend potentially making it 9,999 minutes. 90 minutes is reasonable. I think 15 minutes is too short, fair's cop. But certainly 90 minutes, 120 minutes, that's reasonable, I think. Keeping in mind that if people come along to the doctor's computer and it's open, they can prescribe potentially or e-prescribe themselves medications. Unfortunately, I can't get the really flash ones like the special access schemes and S8s because they do have to re-authenticate when it comes to sending an e-prescription. But certainly when it comes to good computer practice, everyone in the practice should be conscious that you have a secure portal here to some very important information. If you want to lock your computer when you walk away, and don't hit this keyboard shortcut now because it will lock your computer. But so once again, don't do this now. Do this after the call. All right. Windows key on the, yeah, I'm looking at you, Tara. Windows key on the keyboard and hit L. Don't do it now. Once again, if I see half a dozen people drop off the screen, no one listen to me. But Windows L will lock your computer. It takes you back to your login screen, so you can walk away, go to the toilet, go have a cup of tea, have a drink, whatever it is you need to do. But a good idea, as soon as you walk away from your computer, the Windows key and L, and this is the Apple key. Kylie, I'm looking at you because you were tempting me yesterday with Apple keyboard shortcuts. So the Windows key and L, and the second one, the Windows keyboard shortcut, I'm going to give you just for bonus. Windows key and D will take you to your desktop. So if you've got stuff on your desktop, and quite often we've got stuff on our desktop we want to find, that's why we put it on our desktop. And you've got to control, close all these windows up top right, close, minimize, close. Just go with the window D straight to desktop. Yeah. All right. So in terms of, let's go into our holding file. In the holding file, if you've got multiple entries for doctors in here, which is quite common, what actually happens there is potentially, if I'm normally set up in the system as diagnosis and my patient goes to a new pathology lab or a new imaging lab, and they set me up in their imaging system as Dr. Diagnosis, when they go to send me that through electronic means, it's going to come in here as Dr. Diagnosis and potentially not link up to my diagnosis. I'll then have two entries in the system, and you'll quite often have 5 or 6 entries for a doctor, and doctor will go click to check all their holding file. If they're doing that, highlight all the multiple entries of diagnosis in the system and hit that little button down the bottom left there to link all those entries together. All right. Good idea, though. Just check with the doctors if they're comfortable with you doing that before you do that. I have been in a circumstance where I did that, trying to be a good consultant and helping out the practice. It turned out the doctor had those separated on purpose because some of the results were coming in through ones for the local hospital, and they had that separate from the normal general practice, and some of them were coming in for a specialist skin cancer clinic that they also did separately, just to make life interesting. So in that respect, just make sure you check with them before you do join them up. Okay. If you do break it and you go, whoops, I've accidentally added in Dr. Tara into the diagnosis list. Whoops, how did I do that? Click on that list there. You can go in there and unlink, because I don't have any link at the moment. Actually, I'll link that one to me. Yes. And you'll see it's now linked to, and I can unlink that. Right, so if I accidentally link Dr. A Practitioner to Dr. Diagnosis because Dr. A Practitioner was a maiden name or whatever it was, then I can go, whoops, no, unlink that. I'll go unlink, and then when now something comes into the holding file for Dr. A Practitioner, it will go to Dr. A Practitioner accordingly. Right. All right, so let's just select our holding file there, open up some stuff. All right, so here's our results in our holding file. If we've got stuff in our holding file in terms of this, I want to talk about some filter options in here. This is a common problem we see in practices. Currently, you'll see on my screen that I've got a little black triangle over here in the type area here, over here about the far right of my screen. All right. What that basically means is I'm sorting this screen by that column. All right. What would be a better option in this screen, given the circumstances now, what we're looking at is our holding file, I would recommend we sort by the date collected potentially, because that's the date that the particular specimen was collected at a pathology lab or an imaging lab, as the case may be. If we're sorting by that, that now means that that whole screen is sorted by that date collected. Quite often, practices will have the sort by the patient. That's quite common as well. Right? By default, if you've never opened and played with this area in Medical Director, by default, I'm pretty sure that the default sort is on patient name. All right. Now, pretty much what that means is when we've got one sort order, it means that everything is now sorting by that column. So when your doctor comes to you and goes, look, Medical Director is ridiculous. You see, it says it's now got August, then it's got July, and then it's got August again. It's wacky. Who likes Medical Director? Terrible. No, it's just you've got the sort order in the wrong place, mate. If you want to sort it by the date, sort it by the date. Click on there, it'll now sort by date. Some people, no, I want the latest dates at the top and the earliest date down the bottom. Click it again, it'll just reverse the sort order. Fine, no problems, easy. All right. Now, next to that, we've got a thing that looks like a filter funnel. All right. Whole idea of that is that we can sort things out and say, right, I want things only in a certain period, or I only want certain things for a patient, or I only want certain things on a certain subject. For example, here, I only want things pertaining to the PHNEM. Now, I know that's the wrong way of saying EM, my apologies. But certainly, if that's all sorting for that, that will then find all those things. I then just go, okay, it will now sort that list and filter out the other options away. All right, now be careful when you've done that. All right, what I mean by be careful, you now see a little blue thing at the top here saying highlighted columns are filtered. It now tells me at the top left here, 2 of 5 records. And you know, what about the other 3? Up the top there, you've got clear filters. All right, that is now black. All right, if clear filters is black, it means that you have a filter somewhere on the screen. Unless you intentionally want to have a filter on, do yourself a favor, turn it off. Just hit it. If you've ever got filters on there and it's black, do yourself a favor. If you don't know what those filters are doing, turn them off, because you're restricting the information on your screen. All right. All right, in terms of when we're allocating stuff in here, the important part here is if we're doing things like adding recalls to practices, or adding recalls to the practice file, from here, you want to add recall first. All right, because if I put an annotation on here, as soon as I put an annotation on, it will move this highlight line down to the next line. It's being smart for me, it's helping me out. You've done your annotation, let's do the next one. Great, but hang on, what if I want to add a recall to that patient? You've got to go back up and go that one, and then you've got to go add recall again, which is annoying. Not the end of the world, it's just annoying. All right? So a better way to do it, highlight the patient you want to add a recall for. If you want to add a recall for them, hit add recall. And once you've done the add recall, we then do the notation. All right. Let's talk about this add recall, because this is one of the key areas about data cleansing, data quality I want to talk about. All right. This plays into where we were a few minutes ago in terms of that user list and that managed permissions area. All right. Because if I had the managed permission on where I said I'm not able to add recall reasons, I couldn't go add reason. And I go, what's that matter, Grant? What do I care? All right, the reality is what's happening now, about 3.6 versions, or a long while ago now, we changed it so that the recall reason is automatically picking up the subject. This is not a recent change. This is like, I'd say at least 10 years. All right. So whatever the particular subject that is in that particular subject, so if I go here and I go general helix demonstration, just for argument's sake, all right, and go add recall, it's going to bring that in as the recall reason. That's how your recall list goes wacky. All right. And if you've got that managed permission on that previous screen that says don't allow people to add recall reasons, then they have to pick something from the list. Ta-da! There endeth the lesson. All right. Because the whole idea, you go through all this exercise of tidying up your recall list, and the doctors come along and just muddy it all up again. Right. Here I can tidy up the list and keep it tidy. All right. It's not one of those jobs you have to do. I always used to talk about it's like vacuuming. You've got to keep going back and doing it, keep going back and doing it. All right. But this one is now, because we've got those changes in that managed permission area about managing it so that the doctors can no longer do that. They have to pick from the list. And if the doctors need to add a new recall reason, they can come to you as the practice manager, or go to the practice principal, or go to the senior nurse unit manager, or go to your nurse and go, hey, look, why isn't the general Helix demonstration recall type available? Why do we need the general Helix recall demonstration of type available again, Doc? Because it's different from this, this, and this for this reason. Okay, cool, I'll add it, no worries. All right, because then you can still address that particular clinical concern, because there will be stuff on that list that needs to be added from time to time. Absolutely, guaranteed. You won't have it perfect, promise you. All right, so in that respect, really important way to help keep this particular list up to date. All right. Now, in terms of once we've added stuff to the recall list, all right, how do we go through and keep that recall list tidy? Let's go into our recall list. I'm going to grab all our reasons, all our users. Let's just go all, just make my life easier. Let's go search. All right, there's all my recall reasons, all my recalls. Good tip here is to run this as full screen. All right, you can navigate back to your other screen down here, clicking down the bottom by going back to the other screen down the bottom there. Okay, all right. Once again, if we've got stuff we need to do in here, if you've got really old recalls in here, quite often I've come across practices that have got recalls from 2002, the 12-month immunisations. That patient will now be probably about 23 years of age. You're going to call them up and say, come in for your 12-month immunisation? No, man, of course not. Clean up those recalls, get rid of them. All right, have a practice meeting, get some stuff in writing from the doctors and say, listen, anything prior to, I would recommend 7 years. Potentially then be able to go through and delete those particular recalls. Now, it doesn't mean just go through here and delete them one by one, because you could be there all day. All right, don't do that. What you may need to do is, you'll see here, I've got my sort order on due date. All right, so we do by due date. That way we're going to have all the earliest ones at the top. I want to find all the ones prior to 7 years. We do what we call, you can do what we call individual select or range select. Individual select is if I hit my control button on my keyboard and just select an item from the screen, it allows me to select it and also to deselect it. All right. Now, if I want to do a range select, in other words, I want to select like 500 recalls from 2001 through 2014 or something like that. All right. I would then go shift, hold down my shift key on my keyboard. I've got the top one already selected. Select the bottom one, it will select everything in that range. And I could then use the control key to take out the ones I don't want to have selected. All right. Whole idea of this is I could then go down to the bottom of the screen here, go add, which is then going to document an action. Why would I document an action? Because I want to put in the system why I was authorized to delete all the recalls prior to 2014. Because the doctor's got to give it to me on an email. I can refer that. I can even copy it in here if I needed to. The point is, if something goes pear-shaped and it goes to court of law, I got an email that says the doctor said I could do it. Cool. Hopefully, don't delete that email. So in regards to what we put in here, you might put something like, as per doctor's instructions, deleted all email, deleted all recalls prior to blah, 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 et cetera, et cetera, et cetera. Action taken might be other and performed by yourself. In this case, I'm Dr. Diagnosis. Probably wouldn't record that as a contact attempt. It's not a contact attempt. Okay. So I'll then go save. I'm not going to go save. Actually, I'll go save in the circumstance. That's fine. And we'll now see on those particular documented actions, we've got there, as per doctor's instructions, blah, 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 blah. All right, whatever it was. All right. And the whole idea then is I could then do that range select, deselect the one I had previously selected, right click, delete selected items. All right. I want to make sure, though, that I've documented why I'm doing something before I delete it. Because although it's always available on the patient's file, it's just harder to go back later and annotate them all again after you've done it. It's possible, just it's a pain. All right. So do it before. All right. Once, that stitching time. All right. So in terms of data quality, if we're jumping out of there, let's get out of here. Let's go into a patient record. As I say, one of the primary things I'm looking at in here when I'm going into a patient's record here is identifying the problem. Now, if I'm looking at this screen and I've got out-of-date medications, I've got past history from years ago that's not relevant. Now, obviously, I'm a clinician and making that judgment. It's a bit tougher for you as practice manager. But what you could be looking at is looking at family history, looking at social history. When's the last time these things are updated? Why is there no update date on the social history? Right, doctor diagnosis, put a good date there on the daughter lives in Perth, only did that the other day. Great. Well, when's this last time we checked when the patient did lawn bowls? That could have been before they had a leg amputation or something. Maybe they've got the leg amputation and still do lawn bowls. That's great. But that's, if you put a date on there, at least you know then that you've got the accuracy, and that comes back to data quality, all right? When we're putting good quality data into our systems, we'll be able to get good quality data out. If we're not putting good quality data in, no chance of getting it out. All right. Now, where are we putting that good quality data in terms of our progress notes? Everyone wants to put everything in the progress notes. Great. It's wonderful. It's great. But when it comes to things like measurements, when it comes to looking like blood pressures, blood glucose levels and that sort of thing, don't just do it into your notes, okay? I want you to use either the examination down the bottom left here, down the bottom left there, you'll see the examination button. That'll bring up this screen here. This is where I'll be putting my blood pressure. Let's say I'm going to do 132 on 98. I'll need to start taking my blood pressure medication if that's my blood pressure. That's not my blood pressure, by the way. Don't call my doctor. I just saw it this morning. So in regards to in other areas that are useful for the tools and toolbox in here, this is really more for your clinicians, but certainly it's worthwhile pointing out to them there are these shortcuts available. Like if they do a lot of blood pressure, if you've got a doctor that concentrates a lot on blood pressure, the cardiovascular, maybe you want to show them it's Control-Alt-B to get into the shortcut. Up to you. Don't push that fight. Just get them to go here in the first place. All right. Go to blood pressure. This is where you can put multiple blood pressures. So if you've got a patient who's having a potential infarction on you and you are taking a blood pressure reading every 5 minutes, this is where you can put that every 5-minute reading. All right, and go save, come back in, go save again, save. Some people have the previous in the nurse call yesterday. It was mentioned that if I do it in the examination area here, I can only do the one. If you do it through the toolbox, you can do multiple. All right, which is why those toolboxes can be useful to be aware of them. All right? Not a big issue with the weight one. The weight one's not going to change every 5 minutes or such, although it feels like mine does change every 5 minutes. But certainly, you know, things are going to be more stable in certain areas. So be sensible. All right, in terms of data quality in here, really good tool to be using is these management and comment shortcuts down the bottom left here for your notes to provide structured notes. I'm going to do a shout out to my colleague, Katrina Otto there at Train IT Medical. I'm just going to open up, just give me a second to move that away. I'm going to open up Katrina's website, trainitmedical.com.au. Katrina, awesome trainer. She's been training for a long time. I won't say how long because she'll get cranky at me. But it's been a long time, and I've known Katrina for a number of decades. But certainly one useful area from here is basically the medical director free resources. She has a number of resources in this area that is good. One I want to talk to today will be potentially I'm looking at our shortcuts. Thank you. Shortcut samples for use in progress notes down here. This will basically download a little Word document for you. If you don't have MS Word on your machine, you can actually download from Microsoft a free Word reader. There are a lot of practices that don't pay for Microsoft Word, so that you can actually get a reader that can read that. It will basically then give you I'll do it now so you can see how it works. That'll give me a little download there. I'll open up that particular file. And you'll see here there's a whole stack of shortcuts in here. All right. Now, these are just recommendations. Before your doctor comes to me and says, Grant, that's ridiculous. We don't have any fluorescein at our practice, for example. This one here, I'm going to go through the eye injury examination as an example. Right. What we're basically doing there, highlight the text, Control-C on my keyboard or right-click on it, whichever you like. Don't bring all that stuff in because otherwise it makes it a little bit hectic. We'll come back into MD. Go into our management here. Now, management and comment are exactly the same, except for one key difference. You'll see they're exactly the same here. And funnily enough, there's the I one already. All right. Now, basically what happens there, we're going to modify. I'll basically just copy in exactly that location what I've just copied into the system. In this example here, a really good tip when it comes to your shortcuts is put a full stop at the front of your shortcut. Don't put the full stop at the end. The reason being is you might actually have your doctor type in a sentence, examined patient's right eye, full stop, bang, here comes in the shortcut. Not happy. You're never going to have a circumstance where the patient or the doctor writes in, examined patient's full stop right eye or right full stop eye. No. That means basically I'm using full...
Probably, instead of doing a full stop, I'd do the backslash.
Backslash is a good
would
alternative.
probably be a better option. That way, it's not something that's obviously regularly used. And in
Yep.
the documentation that I've created, that's the workflow I've used.
Well done, well done. And you'll also see they're available to all doctors. Up to you guys whether you want to make that available to all doctors. What I usually say to clinicians is if you want someone to be able to change your shortcut, then make it available to all doctors. If you don't want anyone to change your shortcuts, then don't make it available. It's one of the few times I'll tell doctors to get greedy and not be collegial or collegiate. But certainly in that one, it's a case of, look, you don't want other people to come along and modifying your templates or your shortcuts in that respect if you don't want them to be able to do so. Now, you'll notice in here that we've got these little hats, these little, well, it's actually the caret symbol, as in 24 carat, not I've got carrots and onions and all that sort of stuff. It's 24 carat. You'll see it on your keyboard above 6. So you've got 1, 2, 3, 4, 5, 6, 7 at the top there. Above 6, you'll see that little caret symbol. If you put that in the actual keyboard shortcut, and I'll show you what happens. It's really cool. I've got to remember I've changed that keyboard shortcut now from full stop I to /I. So I go to my notes, I go /I, right, and either use a tab button or the space button or the enter key, whatever you like, and it's not going to work because that's probably the way things go. Where did you go? The full stop I? There we go. Probably didn't hit save is probably the right answer there. And basically what's happening there, that brings in my note. Now, why would you want to do that? I had one practice study many years ago, Green. I got a lot of registrars. They're just going to put that in the notes, mate, and they're going to walk away and say, my notes are done. And I say, well, realistically, if they put that in the notes and they walk away from that and go, that's my notes, you should be having a good word with them because what did they actually say? The answer is they're not saying anything, right? They're making statements to which you have to provide the answers. Right, so when this becomes into a court of law and the doctor and the defense lawyer is going, right, well, doctor, you can't remember yesterday I was wearing a blue tie or a green tie. How do you remember in your notes every day that what particular examination it was? Here I'm not making statements, all right, until I actually answer that particular question. Whole idea is at the top here, I've got a little caret button at the top there called jump to caret. Control F5 if you're interested is the keyboard shortcut for it. And that will take me to the first place I need to start typing. So in this example here, mechanism of injury, lathe. All right, click a button at the top there again, pupil size, large, and the reaction to light, yes, etc., etc., etc. And until I put in an answer, I'm not actually making a statement. All right, this is providing good structure to your notes. It's helping your doctors to remember to make sure they put into the notes something that happened or didn't happen. Because remember, if you don't put into your notes what did or didn't happen, it didn't happen. Right, until it goes into the notes, it didn't happen.
This might also be a good opportunity to talk about AI.
Yeah, good idea. Yep, good call. You'll see over here on our right-hand side in our smart bar over here on the right-hand side, which I did get some comments, negative comments yesterday from my nursing colleague yesterday. And of course, I wanted to turn it off. I don't want to turn anyone turning off turning off sidebars, please. So if anyone asks, I will tell you, but don't. Here in the sidebar, well, basically we've got all our various options. I don't have the one in there at the moment because we haven't launched the AI one. It's called AI Scribe. Did I get that name right, Kylie? Is that the right name? She's going, I don't know, I can't remember.
Correct. That is correct.
AI Scribe, thank you. There'll be a couple of different providers on there at this stage with a couple of different price points. Launch date will be before Christmas. All right, so I'll say that again. AI launch date before Christmas on MD 4.3. All right. Now I know I'm being recorded, so Kylie, you've witnessed it. You can help me tell the people internally that I've told them and nailed them all to the wall. Yes, Farah, this will be recording, will be available. Yes, you can chase me down that and probably come to me in January next year and say, Grant, here's a recording of you saying no, it'll be out by Christmas, right? And so there should be a couple of different providers depending on price point, depending on functionality that the doctors want to pay for versus a couple of different providers. So Christmas. In terms of the AI stuff, basically the way it's going to work is you'll have a little tool sitting here in the right-hand side. I can't remember if they would have a phone-based app or not. I'm not sure if that was the case or not, depending on the provider. I think it was. And pretty much it will put a little panel there on the right-hand side, similar to what you would normally have when you do your panels over here on the right-hand side. I'm not going to use that one as an example, but you see there over the right-hand side, there'll basically be some functionality about here. Will be a panel where basically that will be all the text that's coming out. You'll then be able to have a little button down the bottom that says copy. You come back over to here into your notes and you'll go paste. And that's pretty much how that works. All right. So in that respect, things like Dragon, naturally speaking, has been working in MD for more than a decade. So I often get queries about dictation software. Dictation software works fine. We actually, many years ago, we co-shared a stand at one of the GPCEs with Dragon, naturally speaking. So that's how well we operated back in the day. So certainly still works the same in that respect today. All right. In terms of enhancements in here, probably big ones in here, major changes are going to be that email functionality. When we've got letters on the patient's file, we have just move that little bit there. If we've got that particular want to email, it's a particular letter or a bunch of letters. I've got up here, I've now got send email. In Kylie's deck that we've done, there'll be a stack of instructions there on how you set that up, so don't get too stressed about that side of things. You now have the ability to drop this down. You'll see password protect attachments and send emails. Okay? So from here, you'll see it'll basically do its thing, open up the particular, who you're sending it to. Now, if this patient had an email address on file, it would be automatically coming into here. You can create templates in here as well. I'd need to do it from outside the patient's file, so I won't necessarily do it right now. But you can create or customize the templates that will go out from that screen. Quite often people are putting on those templates basically just the instructions that the password for the email is their date of birth in DDMMYYYYY format. And basically and then we'll put some other instructions in there about, if there's any problems, please contact the surgery on blah, 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 blah. But pretty much that's how we do that. Now we can also do that directly from the letter writer. Now, before we go into letter writer, I just want to say down the bottom right here, we've got a whole stack of new fast launch buttons, which you can customize to whether they are going to be templates or whether they're going to be websites. Yes, I have had doctors go, give me the Sydney Morning Herald, give me the Age, give me the, the Red Book, give me the whatever it is that they need to be in terms of that. Now you have up to 10 down there, you choose. So here I've got, say, for example, DBE form, I've got spec referral. Usually the way it works in general practice, number one, template's going to be medical certificate. Number two, template's going to be specialist referral. Number 3, 4, 5, 6, 7, 8. Now that's up for grabs. Number one's going to be medical certificate. Number 2 is going to be specialist referral. 3 might be Commonwealth medical certificate, might be Comcare, might be GPMP, might be TCA, whatever it's going to be. All right, you get to choose down here. The way you do that, you choose letter writer or website. If it's going to be website, then you basically just type in the URL there. If I want to do a particular website, for example, I might come into here and go, what is my website for my Medicare administration stuff? I'd come back into MD, go, right, there's my caption. Down there, I'm going to say it is the My Medicare info. Save. All right. And you'll now see down the bottom right there, you'll now see My Medicare info. If I click that button, it will then open up my default web launcher or my default web browser and open that page accordingly. Okay. Now, so let's go. We're going to make, instead of the DBE form, I'm going to make the DBE form, I'm going to make the medical certificate. So we've got up here in our supplied area, we've got this search button at the top there. You can thank me for that one. We've got the medical certificate. Let's go for medical certificate. I'm going to find, let's say that. So medical certificate, this is the one supplied out of the box. Let's go OK. And let's go change the caption because otherwise I won't remember. Let's go med cert, if I can type. Click med cert. That then launches my medical certificate template. It's going to ask me my questions I normally get asked. Let's tick the boxes to go, yes, you get 1 day off, lucky you. If I want to go back to that patient's file to check something, if I need to go back to check it, I'm halfway through a GPMP or something and I've got a 10-page document, rather than save the document and close it and all the rest of it, just come up the top here, go to Window, go back to the patient's file. All right, I want to go back to the letter again, go Window, go back to the letter again. Okay, nice, easy, quick flick. Control Tab is the keyboard shortcut for it. All right, that's not me doing it with the mouse at the top. I'm just literally doing Control Tab on the screen. All right. From here, if I need to make changes, I can bring in anything here. Clinical details. You forgot to remind me yesterday, guys, about adding in the measurement one. The measurements here, we've got a new field called Measurements Selected. Really useful for your GPMP type stuff, where you've got 20 years of blood pressures. Previously, if you'd brought in their blood pressure readings, there'd be 20 years of blood pressure readings. Not helpful. Now, when you bring your measurement selected, you can choose the appropriate measurement. It will then prompt you and go, right, here's a list of all the blood pressures. Which ones do you want to include? Really cool little feature. So in terms of that one, if you want to bring in signatures in here, it's quite a common thing we want to do. There's a thing in here called auto text. Edit, auto text. All right. I'll show you how we do it. I'll delete my one first. I did a couple of these yesterday. Delete and delete. Yes. All right. Let's go get Mickey Mouse signature. So what we want our doctor to do, we want our doctor to open up, or sorry, to sign a nice white piece of paper, black pen. All right. Not blue pen, not green pen, not red pen, black pen, nice white piece of paper, unlined. All right. I'm going to look for Mickey Mouse signature. Thank you. The secret here is the snipping tool. All right, you're all on Windows computers. Down the bottom left there, click on your Windows button and type in snip. All right, that'll find your snipping tool. If you haven't used this, this should be a practice manager's good friend. Basically, it allows you to take screenshots of stuff. All right. What I want here is I want to open the snipping tool. I'll just click that on the left-hand side. That'll bring up my little snipping tool down there to the bottom right. To move you around again. Now down here, I've got a mode here. I want to do a rectangular snip. I don't want to do the window because it'll give me the whole window. I don't want that in this case. I'm just going to go rectangular snip and go new. All right, there's my Mickey Mouse signature that I want. Yep, that'll do me. All right, now you'll notice on the back of that, it's got a little bit grey. That's why I want a nice white piece of paper. If you've got grey like that, it's not going to come through well on the printer. All right, so make sure it's a nice white piece of paper. All right, Control C on my keyboard, or you can go up the top here and go edit and copy, whichever you like. Both do work. Let's go copy. Come back into MD. All right, go to edit, auto text, add. All right, up here in the auto text, I'm just going to go Control V on my keyboard to give me a paste. All right, down here, I'm going to go .sign. You can go .s if you like. Do not make this available to all doctors. You want each doctor having their own. All right. So available to all doctors? No. All right. Had a lot of practice actually go, Grant, SIGN is too much. I just want .s. That's fine. Whatever works for you, man. Hit OK, close. All right. Now I'm about to do it, but what will happen is I probably don't have enough space here. It's probably just because I know this template and I know the signature. It's probably going to go a little bit funny. I want to show you what happens. .s. See how it pushed the diagnosis down the bottom there off the screen a bit? Let me undo that, Control Z. No, let me do the Control Z, that's fine. All right, let's get that off the screen. Make me some space. All right, come back up again. .s again. And you see now I've got the space. And basically what that means, you might need to modify your templates a little bit to give your signature block a little bit more space, or potentially just reduce the size of the signature. You might say, Grant, that signature's too big. It's a bit rock star, mate. I'll go, look, yeah, okay, we can change that a bit. Let's go edit, auto text. Let's find that signature and go change. All right, I'm going to click onto it. I'm going to just reduce the size of that image a bit. And I'll bring it down a little bit more. And I'll hit OK. And I'll just do it below that so you can see the difference. Now I go .s. You'll see it's a little bit smaller. All I've done is just change the image a bit. All right. Okay, template management. Let's talk about template management. In terms of template management, once again, if you go into 4.3 and this modified template is out of whack and you can't see it, it potentially means that your manage permissions is incorrect at the front screen. Okay. Let's go in. Let's go new. Let's go modify templates. If I need to modify any templates, of course, if it's in our existing list, it's easy. Pick up the template you wish to modify and hit open and modify the template accordingly. If you want to take it from the supplied list into your user-defined list, let's do that now. Let's go File. I want to put that medical certificate in my user-defined list here, all right, the one that's been supplied here. So I'm going to go, right, modify the certificate. There's my medical certificate I want to modify, hit open. Right, I don't want to make any modifications to it. I'm cool with that as is. All right. Actually, what I might do is I might give me a bit more space because otherwise when I'm bringing the signature, it goes wacky. Let's go File, Save as Template. I'm going to call it Medical Certificate. I spelled that right? I think I did. Wow. Miracles do happen. Okay, now in terms of other things you can do in here when you talk about saving these lists and modifying these lists, all right, some things I've seen people do of interesting. Some people put full stops at the front of their common templates, like you put medical certificate there and you put that the full stop at the front of medical certificate, it goes up the top. Some I've seen 1 dot, 2 dot, 3 dot, 4 dot, as in like the top 10 templates. You only get 9 that way because if you do 1 and 10, they both sit next to each other. So you only get 1 to 9 on that one. But keep things together. All right. You want to make sure your certificates are together. Make sure your referrals are together. Don't have things like Prince Alfred referral. Have referral hyphen Prince Alfred. That way all your referrals are together. All right. And if you've got referrals that you're often using, then doctors will commonly refer, to regular clinicians regularly. Use those fast launch down the bottom there. All right. Remember the way we get back into the main screen? Window, back to the patient's file. There's our fast launches down the bottom there. So if Dr. Goodwin is always referring to Dr. Barb, well, then we just put a particular referral template in here, automatically going to Barb for blah, 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 blah. Make it nice and quick and simple, all right? We're doing common things commonly in GP practice, all right? Okay. Sending emails, I thought we touched on that one a bit. I might just touch on the email stuff as well in terms of how that's set up. I'll jump out of the patient's file. We'll go into, is it in here? It might be over here. There it is. Okay. There was those templates before we talked about the templates about emailing. When you email directly from the patient's file, that's where you can sort of play with those templates a little bit, add a template and call it whatever you want to call it. That's where you would have dear patient, first patient name, please find attached your documentation, blah, 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 blah. The date of birth is your password. You would then hit save and you would include that particular template in that template send screen. In terms of the other one there, SMS and the setup here, we've moved this setup out of the letter writer area. Good or bad, depends on your point of view. And pretty much, not the, whoops, my apologies, the correspondence and email setup, my apologies, guys. This one here about the SMTP stuff. This is where you want to get your IT providers involved. I promise you, because the next screen I'm about to show you is going to make most people pause. That one. You go, what the heck is all that, Grant? Pretty much this is pertaining to, this is why you pay your IT guys to be your IT guys. Pretty much this comes down to what is your internet service provider for your email service. And please don't tell me it is Netscape or whatever, because it's come down to some deeper stuff. The good news is that recently, as of 1st of July, I think it was, there has now been an industry-wide change to allow less secure apps at a ISP level, internet service provider level, as per the requirements for our colleagues in the European Union. Well done, guys, European Union. See you in 5 weeks. So actually, it's about 3 weeks. So in regards to that one, does it IT? They don't need to set it up. You can set it up. Where you normally need the IT guys is to decode some of this stuff in terms of where it needs to go. Pretty much, depending on whether it's an Outlook server or if it's a Gmail server, what then needs to happen is you come into here and you put the port numbers in here, you put in those host numbers, you just put back in there those hosts there, like you'd have SMT-mail. This is normally where you get IT to do it. You don't have to get your IT to do it. Normally most people go, yeah, you do it, man. I'm not denigrating our IT colleagues, but why would you have a dog and bark yourself? Not saying they're dogs, I'm just saying as an acronym analogy, like you're paying them to do their IT, you do the IT thing, man. So in regards to that, this one usually where things fall over, to be fair. Okay, in terms of My Health Record, NASH setup requires, in terms of a couple of things in here, in your NASH, your My Health Record setups, mainly first thing is going to be doing is making sure we've got the right details on the clinician in perspective. All right, Tara, are you about to jump in?
Yeah, sorry, I'm just not able to see the screen for what you're showing.
User database?
Oh, yeah, got it.
Yep, cool. So user database, checking into our user database, want to have a look at a few things here in the user database set. Of course, number one is going to be participate in My Health Record. All right, if we're talking about My Health Record, you need to participate in My Health Record. All right. In terms of Exchange, the ERX, this is critical to what's happening in here because it's basically doing the identity management stuff. All right. So must have a registered entity ID here in the ERX script exchange, even if you aren't using e-prescribing. The My Health record doesn't mean you have to be doing e-prescribing. It just means you have to have this ERX system registered correctly. And you have problems, you call our support guys. Participate in real-time prescription monitoring, slightly different to what we're talking about today, but certainly recommend participating in the real-time prescription monitoring, of course. I'm pretty sure you guys were the first state to do it. Well done. Leading the charge, Victoria. Good job. Certainly, we've had real-time prescription monitoring in Victoria since day dot. In terms of enable paperless e-prescribing, up to you. Once again, if you want to do that, that is separate to My Health record. So we must have participate in My Health record status. We must have a HPII, the HIPPII. Everyone keeps thinking you sing the song. No, I'm not singing this song. It's HIPPII, HIPPIO. It's off to work we go. No, it's basically that's a number you get from HPOS. All right. So I'll show you where to put the HIPPIO in a minute. All right. So doctors need to, or the clinicians have to have the HIPPII. All right. You don't need to have an ARPA number in here for this exercise. You don't need to have state registration number in here for this exercise. You need to have qualifications. Need to have qualifications in here. Just, it has to be something. I don't care what it is. It'd be a full stop would do me. It's got to be something. All right. All right. So that one, don't turn on PKI encryption. PKI is old school. It is previous to what we call NASH. I'll talk about NASH now. NASH is the National E-Authentication Structure for Health. Pretty much that is the thing that manages the identity management between you, the government, and who's looking at what data. All right. I won't go through the whole diagrams and stuff about how all the NASH identity management works, but enough to know that you have a NASH, you download the NASH from our dear friends at HPOS and PRODA. Once again, I'm talking about all those acronyms again. My apologies, guys. But pretty much download the NASH from HPOS/PRODA, and I'll show you where to put that now. So as long as those things are done, it'll ask you probably do want to make the change into your exchange. You go, yes, okay, hit okay, that's fine, move on. Get out of there. We come into tools, options, and practice. Where are we? Here's our practice. Hit edit on the one. Now, here's also an important one here. It's that lockout one. And we talked briefly a while ago about the program locking out. I think we might have come in here before. Somebody get confused about yesterday and today. That's where you get your lockout. All right. This is also on the right-hand side where we find our NASH. If it's blank like mine, you're doing it wrong. All right. Pretty much what we do there, we go import certificate. There is only now a NASH, I'm pretty sure. You only just do the NASH. You choose that, leave that button on because you use the same file for the encryption, signing, and My Health record actions. I don't even know why we still have the 3 there. We should only have the 1 in my opinion. Points that to the site P12. It's what I call the site.p12 file. And pretty much at that stage, you'll ask you for a password. The registered officer for the organisation should have received what they call a PIC phrase, personal identity code phrase. And that password you then pop into there. And you do the same thing in Praxoft. In Praxoft, you do it over, this is probably the first time we're going to Praxoft today. I'm going into Praxoft and go to Kyle's. Where am I going? I'm going to...
Sorry, I just had a question in the chat. How can we unlock a patient file when a doctor left it open in his MD and another doctor needs to open it?
Easy one. This is a good change recently. Made it in 4.3 that you can now do this from any workstation. Patient. Manage patient locks. Yay! And that should then show you a list of all the patients in the system that are locked. All right. Obviously, be a little bit cautious of unlocking files that are actually being used, because that causes then, of course, the doctor to be kicked out of the file, and they will not be happy with whoever's just kicked him out of the patient file. They won't come out and thank you, I can promise you. But certainly, if you do have a locked patient in there, you highlight the patient in the list and go reset selected locks. Anything I'm missing? Oh, anything I'm missing on NASH setup, Kyle? If you forget anything there?
Well, anything that's obviously not that we haven't run through today will be in the slides.
Yeah. I'm just thinking for the NASH setup slide.
Just thinking because we've spent so much time on clinical, we might want to jump over to Praxoft now.
Fair call. All right, let's jump into Praxoft. Any questions on MD before we go? Do GPs have authority to manage patient logs? Yes, they do. Yes. All right, Praxoft. Major enhancement changes for Praxoft. I might do something weird and bring up one of Kyle's slides. Now, the slides are busy. All right. Normally, I would be showing these slides, but I do find they are busy, and that's fine. Not from the beginning, silly thing. There, current slide. Okay, is that the Praxoft one, Kyle's, or not?
Nope, they're all in purple, so colour coordinated for you.
You've got to remember I'm colourblind, mate. That's my excuse, and I'm sticking to it.
Just look
As
for
you can see, there's lots of stuff in this slide deck from Kyle's. Kyle's has done a magnificent job. Yeah, it's awesome.
This
Wow,
one's this is the only one for the 4.3. There will be a practice management one as well. This is starting your Praxoft.
Not there eventually. It's giving you an idea also how in-depth this pack is. Kudos, Kylie. All right. So a couple of the big things here. Auto OPVs in Praxoft. The ability to send off patient claims that have been post-paid. What does that mean? I hear you cry. Previously, if a patient had not paid a bill that had a Medicare rebate, you had to pretty much reverse the claim when they came in to finalize the bill, and then rebill it so that you could then transmit it through to Medicare. All right. Not that way anymore. All right. Pretty much what we do now in Praxoft, we have this little button up here in the processing area, online patient claiming. That's the new button there, send patient claim. All right. Pretty much from here, you choose on this screen how far back you want to go. I would not recommend going too far back on the first day. Just go a couple back and see how that affects your system. I have had some people report it created some issues with reporting. I don't know how it created issues with reporting, but nothing surprised me, so don't go crazy here. Because all we're sending off is the patient claim, not the doctor's claim. The doctor's already been claimed off to Medicare. That's already under control. All right, that should be handled through a different system. This is about patient claims where they have paid us, let's say, for example, $80 for an item 23. There should be about $42.85 of rebate going back to the patient. It could well be it was forgotten. It could well be that it failed on the day. It could be whatever. All right. Previously, what has happened to get that to go off to Medicare, you basically went through, reversed it, rebuild it, reprocess it, brought up the appropriate screen for transmit, off it went. Now from here, I can say, right, show me my unpaid accounts. No, I don't want unpaid accounts because then you're going to be doing fraud. Don't do that. All right. Show your paid accounts, or in other words, who has paid you the money. All right. We're going to go through, we're going to do all our practitioners. We can go back, say, as I say, as an example, let's go back a week. All right. And then go show unsent patient claim. There's my unsent patient claim there below. Tick the box. I go OPV and transmit. That will do an OPV for each patient and transmit that off. Now, if you've got a big long list there, don't do 30 or 40 to go, because unfortunately we have to comply with the rules from Services Australia, which says we have to do an individual OPV before each individual claim. That's annoying as all heck if you have 30 to do. Do 5 or 10 to go. All right, because that way I'll do an individual OPV, transmit it through. Do it when you've got 5 minutes. I know that's, you're kidding, Grant, 5 minutes. Are you joking? We don't have 5 minutes. Maybe allocate this to, because this is about getting patients their money back. All right, that's a good thing. All right. So in that respect, go have a look at that. I find that's probably the most laudable feature in the latest update in terms of things. We'll go through, we'll show some others. Hang on. Where are we?
Going to be some new antivirus and firewall exceptions, so I will add those to the slides as well. So that's probably going to be a good one to send to your IT, and that'll rectify any slowness issues and stuff that you potentially may have if you don't have them entered.
Thank you, because that was, we had a query earlier from was it? IT telling us the clinics have had crashing and slowness. Yes, there was practices reporting crashing and slowness in 4.3 upgrades. A lot of it comes back to antivirus and firewalls. Pretty much antivirus and firewalls have made changes. 4.3 has made some changes to the executables in the background just because of the way things have to work. That has caused some slowness because if those particular executable programs are not allowed through the firewall, every time that particular program tries to go to run, it's arguing with the firewall every time it's trying to run. Eventually it'll let it through, but it takes longer. That's why. So as I Kyle put in the pack, some stuff about the what they call the environmental configuration, which is how you configure your environment, which is the antivirus and firewall stuff. All right, so some big stuff there in terms of gender inclusivity, which we'll talk about in a sec. The ability to have a number of different new fee columns. Mainly that was from some of our bigger corporates. I think currently there's about 16 fee columns we have in Praxoft. I haven't come across many medium to small practices that have had problems with 16. Can we access? Yes, you will be getting Kylie's info pack. Promise you, you'll be getting Kylie's info pack. I will be getting Kylie's info pack because it's an awesome pack. So we were talking earlier about actually doing a booklet out of it, so we might do that, yeah. So in terms of making changes in here, we've made some changes to where the patient alerts come up as well. And also put some notice changes into the patient's record and how we're recording next of kin emergency contacts. Might go into Praxoft now. I'm going to show you some of those. Let's edit this patient. All right, so a couple of changes here is the pronouns. All right, so these are all picking up new pronouns for our patients, gender identity, picking up multiple ethnicities. I found out today from someone that you actually can't have multiple ethnicities in best practice. Interesting. Whereas here we can have multiple ethnicities. So, of course, we have two parents. My father is Australian. My mother is Dutch English. So can record that. In terms of the changes there as well, as I say, the gender identities, when we're looking at our notes here and you're looking at patient alerts, we're going through the edit function. View and go into notes. You'll see there's been a slight changes to how this was. Down below, previously the patient alerts was a little line down here. All right, the line that was down here is now migrated up here into its own panel. All right, so if you want a pop-up, in other words, to alert every time Kylie rings up and says she needs to bring her support dog or whatever it is that she needs to bring in for the practice, if I want that popping up in there, I'm going to say patient will bring support animal or whatever it's going to be. All right, and usually I would put in there once again initials, DA. We're going to put there 8th of August 2024. I find it's really good to put dates and times on stuff, not times as such, but dates and signatures in terms of just initials, just because you know when things occur. Certainly I find that in our own CRMs, it's an issue. Will the existing alerts migrate to the new panel? Yes, they will. It's all good. That will migrate. Okay. It's saved. Patient notes have not been saved. Why not? Don't do that to me. Not with demo. Yeah, I'm going to do it with demo. There you go. Let's go close. All right. Normally it won't do that. Trust me. All right. So can we look for a patient using a Medicare number instead of a patient name? Yes, you can. Going to patient depends on where you are. Usually you're going to be doing that from the appointment book, to be fair. If you're looking from the appointment book, Medicare number is going to be a hard one to search from in here. What you can do, what I'd recommend, basically just do a ZZ search. Just go ZZ, go enter. It's going to bring up the search window. You'll see ZZ is highlighted. All right. Just hit delete or backspace on your keyboard to get that out. Then go to your Medicare number field and start typing in your Medicare number there. All right, whatever the Medicare number is, type in your Medicare number search there. I'm going to just do an asterisk search just so I can see if I can bring someone up. Oops, my apologies. There we go. Percentage sign is the wildcard search in MD, by the way. All right, so MD and Praxoft. If you want to go look for what they call wildcard, don't use asterisk. If you did some programming in your life, you'll know asterisk is the coding wildcard. In medical software, percentage is the wildcard. All right, and you'll see there, then it's bring up all my card numbers. There's all the patients that have Medicare numbers. Or in this case, even no Medicare number, because as I say, it's a wildcard search, and they will find the patient accordingly. Okay. If you're doing it from the waiting room, which would be less usual, if possible, we'll go to search for patient, and up there you can do a search for the Medicare number straight away. Okay. All right. Other things we want to talk about on 4.3, Kyles? Anything I'm missing? It's bustingly urgent on Praxol 4.3?
So I'd probably recommend going through and showing locations. So basically, I did mention, I had a practice manager mention that they didn't know how to do letterhead templates in, so for the different locations and stuff like that. So that might be a good one to go through.
Okay, yeah, cool. Let us jump out of that one. Let's go back into MD.
Thanks, Grant. We just had another question saying, sorry, what's the point for the percentage?
Just to be able to search for, if you can't find something, I want a list of everything, just percentage. Basically,
so if you think about someone's surname and you can't like spell it properly and you're trying to like do a PH sound or something like that, or it could be similar sounding
Smith and Smythe. Like it was a guy, if you're looking for a patient, he said his name was Smith. There was nothing coming with the SMITH. I might go in that case, go for patient search, SM percentage, and then it'll find all the patients that'll have SM and whatever's after that in a TH. All right, so then go TH, and then it'll find all the patients. Doesn't matter whether they've got a SMITH, SMYTH, SMQTH. It doesn't matter. As long as there's an SM and a TH, it'll find all the patients in their records are matching those criteria. Okay. Hopefully I didn't distract everyone on that one. Okay. Sorry, Kyles, what were you saying?
So locations. So, so we do the letterhead first, and then we'd go in and set up the doctor so the letterhead actually prints for them. So not in clinical, in Praxoft.
Praxoft, gotcha. Okay, so in terms of in Praxoft, there are a couple of different ways you can add practitioners in for multi-location. It depends on what sort of functionality you're looking for. I know that sounds a little bit confusing. I've had circumstances where the doctors wanted to have different entities here in MD, which is the way we do it. If we do multi-user here in MD, you basically do your setup users. If I go add user, all right, sorry, my apologies, add doctor, all right. If I use the same prescriber number, because this prescriber number should be constant, provider number differs, but the prescriber number is the same. If I set up another doctor with the same prescriber number as an existing prescriber, or it's the same doctor, you're not using up one of your licenses. All right, so in this example here, I've got at the top of mine, I've got 4 prescribers, but I'm only using 1 at the moment. All right. Now, and you can see it in my list, I've got 2 doctors. I've got 2 entries for doctor diagnosis. It's the same doctor because it's got the same prescriber number, the database end. So if it's picking up the same prescriber number, it's not utilizing another license entity. Okay. So from here, I basically go add doctor, put in a whole doctor again. Doctor diagnosis again, put in the same prescriber number. Provider number can be different because it'll be a new provider number for a new location. Pick up that location from here, which should have been done in that previous screen. I'll just take you back to that other screen back over here, which was that tools, options, and practice. And this is where I then go add to add another location. All right. And that's what I did here with urgent care. Just as an example here, I was doing a setting of urgent care, called it whatever I wanted to call it, put in my location that I wanted to call it, put in there my HIPAA-IO. Right, and that's where I put my HIPAA-IO that we talked about before when we're doing the setup there for NASH. All right, that we need the HIPAA-IO and the HIPAA-II. I know we had the joke. This is where we put the HIPAA-IO. All right, so the HIPAA-IO is a health provider identifier organization. Right, so your practice will have a HPIO. Each individual clinician has a HPII, health provider identifier individual. And that way, once that happens, once we've got the HPII, the HPIO, and the NASH, which basically does the decoding of everything, then I have identity tracking between who's asking for what, when, where, and why. So as a Dr. X at location 1 with a location-specific provider number, when the same doctor is at location 2, come up. Yeah, as I say, this is what we're doing now. All right, so Helen, this is what we're doing at this stage here. When we do up particular locations, adding a different location there, once you've got the different locations in here, we then come into the user list here, going to set up users, add a new doctor using the same prescriber number, but with new provider number details. All right, adding into that new location there. All right, once that occurs, now to log into the new location, you do need to log out of the existing location and log into the new user for the other location. All right, so if you are doing it from the one computer and you've got multiple locations, yeah, it's a bit clunky, I grant you. But in terms of if you are actually working at a physical location, as in like Sydney versus Barangaroo. When you go to the other location, you log into the other location under that Barangaroo entity, and you can have exactly the same password there, it doesn't matter. And just log in under that one, and then that will then have the appropriate provider number for that location prescribing under that entity, right? Because the prescriber number will remain the same. The 3 locations, but we share one patient database and share one HPI. Yeah, that could be problematic. We'll take that one offline, Helen. All right. So in terms of that location in here, once you set up, how do you link multiple patients as members of the same family practice? Okay, cool. Let me finish off this one. We'll come back to that one. Remind me about that one. I'll get distracted. In terms of the multiple users in here, when I do set up the add a new doctor in here, it does create a new user in Praxoft. All right. Now, sometimes you want that to occur and sometimes you don't. The reason I'll clarify that is if I do set up a new user here in here and make a 3rd entity for Dr. Diagnosis, for example, or a 3rd location, what will happen in here, from this side here, I'm in the registered practitioners. If I come back into my user list, so go to my admin and go to user list, I'll see at the top here, I'll have a blank user ID for a new Dr. Diagnosis. All right, and I've got to complete that user ID, keeping in mind that the user ID in Praxoft is unique and can never be changed. All right, so pretty much what that means is that if I have DDA there as my user ID and I want to change it from DDA to something else, you can't. I mean, seriously, you can't. I know the database guys, and I've tried to pull favors with them, and they seriously won't let you do it. It's just not possible because in so many areas of the database. So the one thing that cannot change in MD in Praxoft is the user ID in Praxoft. What that basically means is that when I put a 3rd user in here, I can either choose to have that 3rd entity. If I put the 3rd entity in here, then I will have a separate user entity in here. It might be called DDA3 for that 3rd user. All right. Now, if that's okay and you want to have it so that the MD is linking to Praxoft, so if my doctor in there puts their billing in that MD and they bills across to Praxoft and it links across nicely, then that's the way you've got to do the setup. All right. If, however, you just want to have it so that the doctor's got 2 logins for MD, we'll do the billing at our end. I don't care. He doesn't send me the billing through that way. He just sends me a message or will come out and go, here's the numbers. Then you can do it a slightly different way where you can go into the admin in here, go into practitioners. You can add on the top of that one, all right, add over diagnosis again, all right, so you go in through here and go double click again, put in again, and then I go manage location, and I put in different locations from there, and then I have a drop down to have 2 different drop downs. That's more a billing thing, all right, so it depends on what you're after. If you want to just purely from billing point of view, if you do it that way, it makes it easier for you to bill it, but it's going to make the matching between the MD and the Praxoft user break.
It means that if the doctor is in clinical and they're adding in the item numbers, they will not transfer across. So having it set up with different user IDs, so you could potentially do like DR and then the doctor's initials for the 2nd location and things like that. Or you could add in like if it was Bundaberg B and then S for Sydney at the end. So the doctor's initials with the location specific ID.
Of course, if you're doing it where it is actually a separate user, no, just go cancel. If you actually did want them as separate users, you would have 2 separate users in here. Once again, because it's picking up the same prescriber number, it won't use up one of your practitioner allocated licenses. Okay? This stuff gets confusing. Trust me, guys, this gets confusing. If you have issues with this sort of stuff,
I've created a slide for this as well, so it has got an instruction manual. So regardless of which way you decide to go, if you want to go the way where you've got the drop down and you don't need the linking of the billings, just give us a call for our support and they'll run you through that process. I've done it so that the billing and linking are all there based on going from clinical to Praxoft.
Okay, so in terms of, I might take this opportunity to go back to Alice's question. Any chance we can change location of practitioner? We'll get change at the start. Depends if we're talking about from the MD side or the Praxoft side. I'll take that one on in a second. Let's do how do we link multiple patients as members of the same family in Praxoft. If I've got multiple members of the family, basically from here, we right-click and go to our edit patient from here. Generally, if it's a payment linking in terms of you, for example, you might have your child where the mum or the dad is paying the bills. That's when we go down here and we select other for the payer. In this example here, we might say Anna Andrews' payer is Heather. We hit OK. That then has Heather Andrews as the payer as such. That's also an easy way to bring in newborns. All right. So pretty much if you have a newborn child, all right, so I'm going to cancel that one because I don't want to link those together at the moment. If I want to bring in a newborn child, basically add new patient. All right. Straight away, just go in the payment details, pick up the mother or the dad or the appropriate individual. Choose Graham in this example here. Let's go OK. And you'll see it's going to be bringing in their Medicare number. It's bringing in their address details and will bring in their phone number on that new patient's details. All right. Traditionally, it would bring in the patient's, the guardian's surname. I think we changed that a few versions ago, just due to circumstances changing in society. So we no longer make an assumption about surnames. Now you then type in the patient's, the new baby, newborn's new details. You might say Anchor Andrews. We don't want to go too far off the Anna line. Put in the appropriate date of birth. Let's go 01/01/20. You'll notice you don't have to do slashes. You can just do 6 figures on those dates of birth. Okay. Let's go female. All right. A few versions ago, we had a problem where, for some reason, the Medicare gender wasn't picking up and causing problems with billing. The way we just, it probably hasn't had any issues in the meantime, just turn on the transgender, change the Medicare gender to the appropriate gender, make sure you untick this transgender again, if that occurs. It was a bug we had many years ago, if we still get it soon. Now, of course, we're putting in there the Medicare number that was picked up from the parent's file. Make sure you put in the appropriate reference number, the IRN number, the number on the card. Right? Let's say they're going to be 3. Right? Put in there the expiry date. Let's say it's going to be 12/26. That should, all the rest of that should be fine. I should be putting in there with the Aboriginal and or Torres Strait Islander. Put in the rest of the details accordingly and save. Pretty much the way that is linked is that payer detail down here. Okay. Is there any change location for practitioner? Forget to change it at the start. As I changing the location for practitioner, it will depend on how it's been set up in the system and whether you're talking about from Medical Director or Praxsoft. If you're talking about from Praxsoft, the only way it will pick up with the location for the practitioner is they log out and log in on the appropriate user for that location. All right. I'd like to see that improved a bit in the future. I'll work on that, but that's the way it is today. Okay. Patients, have I done NASH? Have I finished off NASH, do you think? Anything I've missed on NASH, my health record setup? Tara, have I missed anything? No? All good?
There's just one, I'm not sure if you've already covered it, but the one where it's saying, is there any chance we can change the location for a practitioner if we forget to change at the start?
No. As I say, they've got to log back in. On Praxsoft side?
Praxsoft.
Once again, it depends on how it's been set up from the clinician side. If we've done it as separate users and we've maintained the separate users between MD and Praxsoft, no is the short answer. You'd need to change the practitioner by literally going into here and changing it over from DDA to DDA2. You'd have to do it at that stage. You could, of course, do a reversal. If it's actually gone through and been billed and it's gone through to Medicare, then, yeah, you're going to have a problem because you may have to do the same day delete. But in terms of that side, when it comes to it, depends on, once again, how it's been set up, because if I've done it so that it's option A, where they're kept separate, it has to be done under the separate practitioners. If it's been done as a, I won't say it's dodgy, I'll just say it's an easier way, let's call it, in Praxsoft, where it's easier for the Praxsoft staff to make the change between the locations, then in that case, you just change the drop down. It depends on how it's been set up in your system, is the longer answer. Okay. Hopefully that answered your question. Patient search utility. Things I need to cover on Praxsoft, Kyles. Anything I'm missing before I dive into MD and do the template stuff, as you said? Letterhead stuff?
No, I think that's fine, unless there was anything else someone wanted. But
I
as
think
I said,
we had in the agenda we had appointment types.
Oh, that's right. Yeah.
Down the bottom, we've got appointment types. Yes, I do see that down the bottom. Thank you. In appointment types, we go back into our appointment book there. In our appointment types, we have a really cool slide I saw earlier from Kylie with all the appointment icons on it as well. There's about 180 something icons, so well done, Kylie. I'm putting all those icons in there for you. And pretty much the way we do our appointment icons in here, we go to our setup and we go to appointment types. Now from this screen here, you'll have some that are preset. Oh, excuse me. The first, I think it's 17. These ones here on screen at the moment are pre-configured in Praxoft out of the box. It pretty much means that you will have your own particular appointment icons or particular appointment types and names. You can call them whatever you like. If, however, for example, you don't do acupuncture at your clinic, and I'm not hassling acupuncturists in any way, shape, or form, if you want to change that from acupuncture to something else, you simply overtype it and call it whatever you want to call it. Let's call it something else. All right. You can change the icon here. Simply double-click on the icon. You can select an icon or a color. If you're choosing the icon, as I say, Kyle's has given us a list of all the icons in the in the deck. We go and press on Browse. You'll see there's various icons in. I particularly like the Sergei Kokoda ones, just for what it's worth. We open that one up, and you'll see all the various little icons in here. Don't worry, we've given you a much better way of seeing all these expanded up. Just by giving kudos. And choose whatever particular icon it is. And instead of that being that needle, acupuncture needle set there, that would then become the stethoscope in that example if I use that to change it over. As I say, we can use a color. And we can change it. So now if we do scroll down, we will see that there is another set of appointment types below that. There a few versions ago, we actually increased that by 24 to get up to now over 42 appointment types in Praxoft. If you want to then change, I generally like to recommend to operate in the first 16 if you can. Main reason being is that if you do go into the more in-depth one, let's say we go over here in a custom type 1, I'll just call this example special 1. All right, and we're going to put an icon here. We'll make it a color. We'll pick a color and we'll go make it a red one because they go fast. Go OK and go save. All right. Now pretty much let's make an appointment for my patient. Let's go Andrews, enter. Choose one of our patients at the top there. Coming up that alert again. Close. Now I want to type that. If I go down here to the type area, you'll see it's giving me my first 16 straight off the bat. It's nice and easy to select that first 16 or 17. I think it actually might be 19. Don't count it on me now. But certainly it'll give you that first list easy. If you're trying to go into the more, it just makes it a bit harder just to literally use your mouse to get there. All right. So I tend to use, if you can, stick into that first lot. If you need to go into the next lot, then certainly do so. But just be aware that it is a bit harder to get to. These ones in here have keyboard shortcuts. These ones over here do not have keyboard shortcuts. All right. We cannot add more keyboard shortcuts from here into here because virtually all the keyboard shortcuts are taken in Praxoft. And Kylie has got a slide there with all the keyboard shortcuts. Thank you, Kylie. So that one should be managing our appointment, sharing our permissions and configuring users. Okay, I think we've done that one. All right, so in terms of patient search utility, anything I haven't covered there? Anything I need to expand on a little bit there, do you think? We good? Questions from the audience? No, we're good. All right, let's go into patient search utility and do those letterhead stuff as per Kylie's guidance. In terms of the patient search utility, let's touch that first. Search and patient. All right. Pretty much this is where we're coming back to, we're doing the whole circle back to the beginning of the webinar where we had data quality and data cleansing as the first thing we started out with. All right. This is why we do data quality and data cleansing, because when we go and do our search, we actually find the stuff we're looking for. All right. One of the things we didn't talk about was coding versus non-coding. If you don't have doctors that don't do their coding, what I mean by your coding is doing things from free typed pick lists rather than picking it from a pick list as such. And let me just expand on that momentarily. All right, so when we're coming back into here and we're doing our various notes for our clinicians, and this is always a bit of a tricky conversation with doctors, but it's possible. When we're coming in here and doing our reasons for visit, please do your picking and things from pick from list rather than from our little free text down the bottom here. Because if I select from this list up here, well, then it will appropriately code and back check all the stuff I've got for the patient in question. It'll go through and do my interaction checking. Now that I've advised the patient is non-insulin dependent diabetes, then I can look that up later, which is what I'm about to do now. All right. So if I've got that patient coded accordingly, that's all good. I can jump out of there. We come back into our patient search, go search and patient. And normally what we're looking in here is for things like, find me all my patients that have got diabetes. Find me all my patients that have got anxiety. Now, quite often it might be pharmaceutical companies might be helping us to run programs. It might be do drug trials. It might be they're looking for, patients to assist them with checking for drug trials, whatever the case may be. That's normally where we're coming into this area. We can be looking at patients on particular drugs, patients taking particular drugs from particular classes. So it might be antagonistic inhibitors or whatever the case may be. It might be conditions where you're looking for patients that have anxiety, the patients that have NIDDM and that sort of thing. Now you might say, Grant, what happens if my doctor didn't do the coding? How do we fix that? Good question. Don't worry. Kylie has a slide for that one, but I'll talk about it briefly. In terms of going into here, we basically go to our maintenance area here. In the maintenance area here, we have in database tasks, we have our diagnosis coder. All right, and in this diagnosis coder, if I have entered any in that are actually not coded correctly, they will be appearing here on the left. And over here on the right-hand side, I can then go, right, find me all my NIDDMs, find them and link them together. All right, and that way, if there's any been free texted in the system as NIDDM, when I then hit link, it will then go back and then link that particular NIDDM to all those NIDDMs that the doctor free texted. Okay. Thank you, Kylie. All right.
Chat the Med Relief 6-monthly TGA reporting, because I know a lot of practices weren't sure how to collect that, and that will be in the advanced search section. Okay. So I have added 2 options there that practices can utilise.
Yeah. That's the advanced search section down the bottom there. Pretty much that's an SQL coding area. From time to time, practices do approach us and they want to get specific data out for clinical reasons. It may be they're assisting local university to conduct a particular drug investigation or a condition investigation, whatever, and basically send those queries through to our support team, and our support team should be able to send that through to the appropriate department to get you some assistance if possible. We'll have a look into that. More often than not, there isn't a charge for it. If there is a charge, we're going to have a chat to you about that and talk about that before we start charging you. But certainly most of the time, that's usually done at no additional charge. In terms of search criteria, usually what I'm looking at in here is, I'll be honest, the most common way I'm looking at this particular screen is I'm looking for all my patients that are inactive or I want to make inactive. All right. And why would I want to make my patients inactive? Because especially if I've got accreditation coming up and I've got patients in my database that I haven't seen in years, should I be held accountable for us not having completed their latest drug data information? Yeah, you actually are. How do I fix that? This screen here. All right. Now, how I would do that is I might say, I'm going to say visit by any doctor, have not been since, not seen since. Let's go and go back 7 years. All right. 7 years. And you'll see now down the bottom, here's the important part. Just make sure when I'm in there and I'm looking for a certain thing that's putting in my search criteria, what I think it's actually going to search for. All right. So I then go search. It's then going to find all my patients I haven't seen in that time. All right, I'm going to have a review, make sure, is there any that I've got wrong? No, I haven't. I can then go inactivate. I'm not going to do it now. Then I then go inactivate, and that will inactivate all that patients on those lists. I'm not deleting their files. I'm not getting rid of their files. All right, I'm just simply moving them to an inactive status, which then affects my clinical data statistics. All right. Now, there are clinical data statistics here in Medical Director, and it is also, you see programs like PenCap, Polar, Primary Sense, all those sort of population health programs, depending on what your particular interest is in that side of things. You'll be able to then use that particular tool accordingly. So if we then come back here into the tools area, going into that particular system,
So I have just
Clinical
added
data.
a link, just a slide that I've added in. So the reason for the 7 years is actually based on the guidelines from these different companies that I've just popped in the chat. So what I would recommend is obviously go through and check out the guidelines that, RSCGP, AAPM have posted for you guys to be able to see where you should be doing stuff. I've added each of the actual icons have the link to the website, and I've tried to guide you to the right areas as well. So if you're finding that you're not sure about the information, obviously check with either your local PHN or, these sorts of companies.
Yep. And you'll see that now on my screen that I have a list of what my current clinical data statistics are. If I go through and make some of my patients inactive and they have missing current medications, when I make those patients inactive, that will increase my compliance factor there, which is the whole idea here. Our PHN in previous years has done a little bit of a policeman role. They don't do policeman role these days. They guide us, and basically we're guiding towards that ideal of having 100% of our patients with past medical history. It's not realistic, really. If we do have a look at our print data statistics, it'll actually show you on the screen there what the particular threshold here is. So allergies and adverse reactions should be above 90%, as you can see. Mine is currently at 82. I'm pretty close. I'm doing all right. Current medications, you've got a little bit of work to do, Grant. You're currently at 58. We've got to get to 75. My past medical history, I'm doing well. All right.
Sorry, Grant.
Just to answer your question, as long as Praxopt and Clinical are linked, yes, it will activate both. If it's not linked, then no. So the answer is yes or no, depending on your setup. And then
when inactive makes an appointment, do we have to activate the patient again? You don't have to make a patient active again. Generally, we would recommend you do, because if they are making an appointment, they will be active again. You don't have to.
Once the clinician or the patient's file is opened, it will reactivate them.
I think it gives you a prompt. It used to be an automatic reactivate. I think now we have improved that so that you are now prompted to go, do you want to make the patient inactive, or do you want to make the patient active now? So I think there's a slight change recently on that one. All right. Okay, that's all right. In terms of MD utilities, I touched on one there earlier about MD utilities. I do want to touch on those letterhead though. So allow me to, how can we do a search to merge patients? Can we do a search to be able to merge patients? You can do a search to be able to merge patients. Usually you're doing that from the open patient screen here. So if, for example, I'm then going to find my Andrews, I would then say, for example, Melissa and Maureen. All right. I then go merge. All right. It finds my two patients I want to find. It goes Melissa and Maureen. I go next. All right, we'll choose the master. Let's go that one. Next. All right. Let's choose that one then. I go next. All right. It's asking me to merge those two patients together. Now, obviously, the most important question is how do I merge patients? Is how do I unmerge patients? And the answer is right now, really hard. In the 4.4 version, hopefully coming up next year, we will have an unmerge utility. Hopefully, don't hold me to that. I know that the guys in product, I wouldn't say promised me, I nearly said promised, but they have recommended they're going to get that done by next version, which would be great. If, however, you incorrectly merge patients now, you basically need to go back to a backup where it was pre-merge and extract that patient data and then re-import that patient data back into Medical Director again. All right, so probably the most important question about how do I merge patients is measure 15 times, cut once. I'm going to say measure twice, cut once. I'm going to say measure 15 times. Like, make sure you got the right data here, because unmerging a patient is a nightmare. And if you try and do it manually, you're literally moving results and documents backwards and forwards. That's a headache in and of itself. As I say, in future, we will be building a unmerge utility, and I look forward to the production of that utility.
I think one of the worst mergers is definitely twins, and especially when parents are naming their babies similar names too, which can obviously look distracting because one, their date of birth can be the exact same, their address, all their contact details, their parents, so just keep that in mind, that you're definitely looking at the name and they are definitely one or two people.
Now, probably if I look at your question here in another way is, can I do a search on my database to identify who is duplicates in the database? You can certainly just do a wildcard search, just do a search in the system, just go search and go patient, and that will get you everyone. I'll just go all patients at that stage. It will give you all 30,000, 20,000, whatever patients you've got. That's going to be pretty hard to go to that list manually, to be honest. There is a utility you can get from our support team to merge duplicates. Generally, it's only provided when we're doing database merges, because the possibility of inappropriately merging incorrect patients is quite high, as Kylie's already mentioned there with the twin patients. That would be an absolute clanger. Using that particular merge utility would cause particular issues quite potentially. So just be cautious with that.
If you go to patient IHI exception report, that'll show you any patients with the same IHI number.
Good job. Well done. All right. MD utilities. What do we got? Where are we? MD utilities. All right. MD utilities. You should see on your desktop a spanner. All right. You'll see, hang on, Grant, you've got two spanners. Where do you get your second spanner from? We'll come back to our main spanner in a minute. This is a new utility we released relatively recently. I think it's only been out for the last 6 to 8 weeks. Generally speaking, it is as you can see on the screen, our MD My Medicare import wizard. Kylie has done up a slide for us with the appropriate link there. If you go have a look on our webpage, if you do a search on My Medicare, you will hopefully find this particular page called My Medicare Administration in Medical Director, your essential guide. It will take you through and give you all the screenshots on what you need to do with My Medicare setup and that sort of thing as well in Medical Director. Pretty much what this tool that I'm about to show you does, it enables you to go onto HPOS, which is this bit here, step 3, and export your patient list. And basically what that does is then exports a list of your patients that have registered with your practice as their practice for My Medicare purposes. Once you download that list, what do you do with the list, I hear you say? You'll then grab that utility that you would have seen me just grabbing just a second ago, that one up here, and log in accordingly. All right, you'll point to that particular file that you just downloaded from Proda, although I don't have that file there now. Click on the file and hit open. That will then go through and import all the patients that have a flag of My Medicare status in Medical Director for you. So currently you would have to now go into Medical Director and go into each and individual patient file and individually flag whether they are My Medicare registered with you or not. I'll just go back into there. Really nice little useful tool here between the photo and the side of the demographics. If you double click, shortcut into the patient details. All right. And you can see there, this patient is registered with My Medicare for My Medicare. If you run that particular utility I just showed you, then certainly that will enable you to say, download that list from HPOS. You've got to go and log into HPOS, download the list of patients that are registered with you for My Medicare. Once you've got that list, you can run that utility and it'll then go through and update that for all your patients, so you don't have to go and do that one by one for all your patients. You're welcome to do it if you want to, not hassling you. There's a better way. Okay, so in terms of the other utilities that we have in here, probably the most important ones, in my opinion, will of course be that diagnosis coder. That's important. Also, we have the ability to change or update our recall lists. We have here in, whoops, my apologies, wrong one. Merge clinical list, my apologies. In here, you'll then have 4 different options there. Recall list doctor, immunization list, addressable categories. What are these things? How do they work? In your recall list currently, this will be a list of all your recalls in your database currently. Usually you'll find 1 immunization, 2 immunization, 3 immunization, 12-month immunization, 12 months immunization, 1 year immunization, for example, and you keep going. What you basically do in here is to tidy this up, is go into, let's say, for example, I want to get rid of patient documentation. All right, you'll see that these lists should be exactly the same. That's intentional. All right, you'll see below there it's got 2 fields, replace and with. All right, basically what I'm telling it is I want to replace all my recalls that are currently called patient documentation, I want to then get them replaced from patient documentation to full medical checkup. Do not go okay. Show you what happens if you go okay. Nothing. Does nothing. These goggles, they do nothing. We go into here, we go back to our recall list. I go patient documentation, I go full medical checkup, and I then go change. All right, now usually at this stage, when I'm showing this to doctors and showing this to practice managers and showing this to nurses, it's at this point I usually pull out my ruler and go, literally pull out my ruler. Hopefully it's a wooden one because it's a metal one, this will hurt. Is I'll wrap them on the back of the knuckle and go, get your hand off the mouse and read it. All right, because at this stage, if you then join your PAP tests up with your PSAs, you're going to have a bad day. All right. So at this stage, it's your last chance to stop scrambling the egg. All right. Because if I now hit yes, and it shouldn't have been yes, bad things are going to happen in my database because all my things that were previously patient documentation recalls are now going to be full medical checkups. That's a bad day. All right. So take your hand off the mouse, read what's on the screen right now. And if you're actually happy with it, then hit yes. But this is one of the screens where you literally take your hand off the mouse and go, read what is on the screen right now. Because if you don't and you bugger it, it's going to be a real nasty cleanup to go fix it up. All right. So, and the whole idea of this is once we then make this change, if we've got that original managed permission set correctly where the doctors can't go in and add more recall reasons again, this then tidies this up longer term. We circle back to the data quality and data cleansing that we were doing at the very beginning. All right. Okay, so let's say no at this stage because I don't want to do that at that stage. In terms of your recall list doctor, this is quite a common one here. When you go into medical director and you go into the recall list, you'll often have in the recall list, you'll have doctors that have been there for years. There may be doctors in that list were never there. All right. And basically what happened there was that many years ago, when you imported patient files, it would import, if that patient had seen Dr. Barb Repkin at a medical surgery 20 years ago, it would bring Dr. Barb Repkin in down here. I've never seen Dr. Barb Repkin. We fixed that in the meantime, but that's where it may well have come from. All right. So if you do have people in here that aren't inappropriately in the list, what you do is you come back into this area here, you go recall this doctor, and you merge the doctors that weren't supposed to be in that list, and you merge it over to one of the users that is currently at the practice. So that way that anything that was on Dr. Barb Repkin inappropriately, and there probably wouldn't have been anything on Dr. Barb Repkin inappropriately, but if there was, it would now merge over to Dr. Diagnosis so that when I then go replace or change in that case, it's now going to change from that Dr. Diagnosis to, in this case, sample practice manager, go change, and that will then merge all those recalls from that person to that person, bada bing. Now, what will then happen is that that doctor diagnosis will then, or whichever particular doctor I'm trying to get out, will then disappear off this list down the bottom left here. All right. That's how that tidies up. Okay. Other things in there, don't tend to find the immunisation list. We play with that one that much. Yeah, yes, you can. I don't get much traction there. Nurses love playing with that one. I don't see there's that much benefit in that one from a data cleansing. Not saying it's not benefit, but I wouldn't get much bang for the buck out of that one. In terms of address book categories, I remember taking this one to a practice who had spent, the senior practice receptionist had spent 6 months tidying up their address book. When I showed her this one, she was not very happy with me. Because they'd literally gone through and updated all of their address book categories one by one, whereas you can actually go into here, and if you have a number of different ENTs, EN and T, ears, nose and throat, ears, nose, AND throat, you can join all your ones up here by same way, highlighting on the left-hand side the appropriate item, replacing with the appropriate item on the right, hitting change, away we go. All right.
Recommend, especially with your address book, that we do have health share that's fully integrated. So it means that they're maintaining and updating that address book. So it's definitely less work that your team have to do when things change. So if you are finding that, you know, there is doctor details missing from health share, if you enter as much information so that their team get alerted, they'll add it within 24 to 48 business hours. So that's also going to reduce the time that you're having to spend collecting that data and manually entering it.
Now, I realise I'm running a bit short on time. But last but not least, I just want to go through the import-export. Traditionally, we have had an issue when we would export patient files from 4.2 and prior, where we would send it off to a lawyer or send it off to solicitors, whatever the case may be, but it wouldn't then include all the documentation that we had received from third parties. And the position we took at that stage was that, look, realistically, that particular report was provided by Dr. Grant Smith to Dr. Diagnosis. Do you actually have intellectual property rights to be able to pass it on to someone else? I'm not going to go down that one these days. We've worked on the principle, look, let's not worry about that. Let's just give the letter to the appropriate people and let them worry about who owns what, when, where, why, in what court of law and wherever you come to. In terms of the change here in the export area, you'll see when I go to the next screen, there is now a third option. Previously, we only had XML and HTML. XML should be generally sent to other practices using clinical software, usually Medical Director or BP. I know that when we change our software, that when we go to export something, BP quite often have challenges to pick it up. When BP do an update, we quite often then have challenges trying to pick up their latest data file because they've made changes, and we've got to then go back and change our import utilities. So there's always a little bit of fiddly there. Suffice to say, if we are exporting to XML, XML is usually imported by Medical Director / best practice programs. HTML can be opened by anyone because it can be opened on just in Google. All right. So usually if I'm sending HTML, I'll send those to the lawyers. The problem with both those files was, as I say, is that quite a lot of those documents that we received were not being sent. Now in the PDF option, when I have a PDF option here, it does export that as PDF, so that is much more universal than a HTML or an XML program, because virtually every program, every system can open a PDF. But that also now includes those documents that we previously didn't include. They are now included in that PDF export. All right, so if you are exporting and you do want an absolutely complete patient record, clinical PDF is probably the appropriate way to do that export at this point in time. Conscious I'm running short on time. Kyle's, you got a couple of minutes? Anything I've forgotten?
I think we'd probably want to hand over now, but there is obviously a questionnaire and things that will be sent out, as well as
how
all
do
of
we
the
get
slide
updated
deck.
info for our address book? That's in the pack. Yep. That's
Yeah.
in the pack. Exit that one. Is there anything I haven't covered? Data quality, 4.3, template management. I'll just touch on the templates quickly because I never think I actually got there. We'll get there eventually. Templates. In terms of putting things on your letterhead, you can simply use that snipping tool to bring things in. I'm going to see if I've still got one of the snipping tool. Yeah, I've still got my Mickey Mouse pal there. Let's go Control C. I want to go into my letter writer. Let's go to letters. Let's do it the slow way. Let's go right click and go add. If you're not coming up on this screen, if you're coming up on a blank screen like this, when you or your users go into Medical Director Letter Writer, go into the File drop-down menu, go to Preferences, go to Defaults, turn Display File New Window off, turn it back on again, hit OK. When you come back into the letter writer, what will then happen is you should be hitting that screen there, which will pick up your new template screen. All right. If I want to make changes to my medical certificate here, I'm just going to go cancel at this stage. I'm going to go File, Modify Template. Once again, if that modified template is grayed out, go back and check that user permissions on the setup user screen. All right. Let's go modify our medical certificate. Let's open. Let's go to the beginning of that template. All right. I want to have this particular image come in every time. Let's get to the bottom of that. Let's move that down a bit. And File, save as template. And I call that medical certificate with letterhead. Save, run, up, go. There you go. That's the easy way of doing it.
I just had one sort of like last question. There's a how to get info for our address book in the chat.
Which one was it? How do we?
I'm not sure the context on that one. How to get updated info for our address book.
Yeah, so that one was, we'll talk about that one. It's in the slide deck about the health share. Yeah. You can also get that in there as well.
Thanks, Grant.
All right. I'm going to hand back to you, Tara, with a couple of minutes to spare for once.
Perfect. Thank you so much, Grant and Kylie, for all that information. Just so much to cover in that. And there's so much more in that slide deck that we will be sharing out. Please do keep in mind that all of these medical director sessions have been recorded. That's for the general practice ones, nurses one, and the practice managers one today. Now, if you can please give us some feedback, good, bad, ugly, and just some topics that you'd like us to cover for next time. And if you'd be interested in doing these sessions again, if you can scan the QR code that's just come up on your screen. If you've got any questions, you can email us at digitalhealth@mfin.org.au. Thank you for coming and attending. And once again, thank you to Grant and Kylie for that good presentation and how much information. I've learned a lot these last 3 sessions. I'm not sure about you, Barb, as well. There's just so much more about medical director than I knew before. So this is really great information. But please, do that survey, and thank you for attending today. And we'll send the info pack as soon as possible. Thanks all. Have a great rest of the afternoon.